Welcome, everyone. I know we're excited to welcome Dr. Nathan Bryan. So I've been following Dr. Nathan Bryan's research for many, many years now, and I consider him the pioneer and I think the authority when it comes to nitric oxide. And I'll let him talk to him a little bit about his credentials and everything from that perspective. But we'd like to welcome Dr. Nathan um, Bryan to the call today. And if you have any questions, you can use the chat, or we can use the after we're done the talk today, you can just use a little notepad, and then we'll ask lots of questions as we go on today. So yeah, we're very excited to welcome Dr. Nathan Bryan. So thank you very much.
It wants me to chat.
Thank you, Diamond.
My pleasure, Nathan.
Yeah. So we'll go ahead and get started. And if you don't mind,
this is a new feature.
Just mute your audio, and then if you got questions, we can. Okay. Can you hear me, Diamond?
I can hear you. Yeah, I just wanted to.
Okay, great. There, so. All right. Well, again, thanks a lot. And so what I thought I would do was just kind of give you a 20-year journey in 45 minutes of kind of where we've come in terms of research and development and really discoveries around nitric oxide. I spent the last 25 years in academia really trying to answer four fundamental questions. And how does the human body produce nitric oxide? What goes wrong in people that can't make it? What are their clinical consequences? How do they present clinically? And then number four is, how do you fix or restore endogenous NO production? And so that's the story I'm going to tell you. And so at the end of this, I hope you have a kind of a conversational understanding of nitric oxide and hopefully appreciate nitric oxide beyond hypertension and really start to look at the mechanism of many diseases that may be due to insufficient nitric oxide production. I have a number of conflicts of interest. We've commercialized a lot of my discoveries out of the University of Texas Health Science Center in Houston, where I receive royalties from issued patents that we've commercialized through these companies. So my job is to see what everyone else has seen, but to think what no one else has thought. And that's really what I hope to share with you tonight, kind of some seminal discoveries we made and some astute observations that led us to think differently about the production of nitric oxide. But beyond that, I want you to think more broadly that chronic disease is caused from two things and two things only. And it doesn't matter if it's Alzheimer's, cancer, heart disease, diabetes. It's only two things that cause these diseases. The body's missing something that it needs, or it's exposed to something that it doesn't need. And so the end result is a disruption in nitric oxide production, decreased circulation, inflammation, oxidative stress, and immune dysfunction. And those are the hallmarks of every single chronic disease that we know of. So if you can address these two things, remove the source of exposure of toxins, and then replete missing nutrients or minerals, then the body heals itself. And that's really what we're trying to do. So I'm going to start with kind of a 50,000-foot view of things and look at, non-invasive imaging and SPECT scans. And SPECT scans are really imaging modality that determines how well perfused an organ is, and in this case, the brain. So a healthy brain is well perfused. There's well contoured, means that every part of the brain is getting sufficient blood supply. On the right, you're seeing here, this is a patient with chronic traumatic encephalopathy. And these holes in the brain are reflective of focal ischemia, or areas of the brain where there's decreased blood flow. And so with disruption in blood flow causes disease. As the Heart Fit Clinic, obviously you're familiar with an angiogram. If there's an occlusion or thrombus, in this case in the left circumflex, if you don't restore blood flow to this part of the heart, then this patient dies or over time develops heart failure and dies and perishes years later. But what this shows here, if you can quickly aspirate this thrombus in the left circumflex and restore blood flow to the myocardium, then you can restore normal cardiac function. So the timely restoration of blood flow is critical for the maintenance of organ function. And it's not just brains and the heart. If you dig a little bit deeper, it's these motor neurons or sensory neurons that are dependent upon adequate blood supply to get the sodium and potassium there to initiate an action potential. So when we develop endothelial dysfunction and these diseased blood vessels, then that's the onset of neuropathy. So the whole point here is that every single chronic disease is characterized by decreased blood flow. If you can restore blood flow and perfusion to those organs and tissues, then you can correct many of these chronic conditions. So the fundamental question is, how do you do that? And that's
that's
really the goal.
Yeah, and that's the big thing when we talk about artery disease. It's a muscle, right? It's not a pipe, and that's where the
That's right.
common misconception. People think about this artery like clogging up, and cholesterol builds up, and you have a last piece of pizza, and you end up with a heart attack. And it doesn't happen that way. And this is why it's important that you know. And you know, you're laughing at this, but there's a lot of smart physicians that talk about this artery like a pipe, and it's nowhere near to that. And so that's really to explain that part of it to the artery wall and how nitric oxide comes into play. This is where it's so important on that end of it. But yeah.
Yep. We'll dig a little bit deeper.
Yeah.
You know, in 1998, the Nobel Prize was awarded for the discovery of nitric oxide, and this was a famous quote by Val Fuster: "The discovery of nitric oxide and its function is one of the most important in the history of cardiovascular medicine." We're now 25 years this year post Nobel Prize, and I show this schematic here because, you know, you brought up a very good point. Nitric oxide is obviously a vasodilator, improving blood flow, but this paper in 2015 realized that nitric oxide is required for oxygen delivery. So when we breathe in oxygen, it binds to the iron of hemoglobin. When it goes from the arteries to the vein, it undergoes an allosteric transition. Oxygen comes off and picks up CO2. But oxygen will not come off unless there's nitric oxide bound to a single cysteine residue on the beta chain of hemoglobin. And so without nitric oxide, you don't get oxygen uptake and you don't get oxygen delivery. And I'll bring that back at the very end, and I'll show you some results from our COVID drug study. We had a phase 3 clinical trial for our nitric oxide drug in COVID. But it's involved in every biological function, from the molecule that tells our own stem cells to mobilize and differentiate. It's a neurotransmitter, the central nervous system. It's a bronchodilator as well as a vasodilator. It's the molecule responsible for sexual function and erections in men and women. And it's also critically important in our innate immune response. It's how the monocytes and neutrophils kill off bacteria and viruses. Your ability to produce nitric oxide predicts your immune function. And in fact, if you become nitric oxide deficient, you become immunocompromised. And these are the three gentlemen who shared the Nobel Prize in 1998 for the discoveries of nitric oxide. And it was Fred Murad who recruited me to join the faculty of UT Medical School in Houston back in 2005. So a lot of the work we did early on was through the Institute of Molecular Medicine, where we're really charged with developing safe and effective nitric oxide-based therapeutics. So let me just give you kind of, again, a broad picture, and then I'm going to distill down into mechanism. But if you look at kind of the three main objective kind of readouts of aging and chronic disease, there's telomere shortening, mitochondrial dysfunction, and loss of stem cell function and repair. So all of those contribute to aging and longevity. And I presented this unified theory of aging maybe 15 years ago because nitric oxide is what controls and regulates the telomerase activity, mitochondrial biogenesis and function, and mobilization of stem cells. So if your body's deficient in nitric oxide, you're going to have short telomeres, shorter lifespan, dysfunctional mitochondria, and lower numbers of mitochondria. And your stem cells don't get the signal to go and mobilize and repair and replace dysfunctional cells. So this is really the core of everything we know mechanistically about aging. And I'm going to go through this really quickly because I'm going to assume that everybody on this call is familiar with these. But the telomeres are the ends of the chromosomes that basically shorten with each cell division. But this is based on this telomerase enzyme. Again, a Nobel Prize was awarded about a decade ago for the discovery of telomerase. But these are the papers that show that nitric oxide is required for telomerase activity. And it provides now the opportunity for innovative therapeutic approaches using nitric oxide active compounds. And not only does it affect telomerase activity, but it affects the nuclear expression and transcription of the telomerase enzyme. So
and the telomeres, yeah, and the telomeres, sorry to interrupt you, but the telomeres can lengthen, right? That's the whole idea on that side of things, because people think, oh, they're short, I'm in trouble, it reduce my, like that's a genetic test that we can do to see what your lifespan is, and it very related, a lot of great studies on telomeres and cardiovascular disease, but it can lengthen, and that's the key, is that.
Yeah, that's right.
You know,
so now, beautifully, the mechanism has been completely elucidated, so we can affect not only the genetic expression and transcription of the telomerase enzyme, we can actually affect its activity through improving nitric oxide production. And then there's mitochondria. Obviously, mitochondria are the energy powerhouses of the cell. They create cellular energy. And it's nitric oxide that controls basically every aspect, metabolic aspect of mitochondria. There's a number of studies showing intermittent fasting, caloric restriction, the sirtuins. All of this is dependent upon nitric oxide production and the function of eNOS. And this is through the PGC1 alpha expression, mitochondrial biogenesis. But again, if the eNOS enzyme is uncoupled and you can't make nitric oxide, you can do intermittent fasting, caloric restriction, exercise, but you're never going to get an effect on mitochondrial biogenesis, nor the improved function of mitochondria. And nitric oxide actually affects the oxygen diffusion in the tissue. So it extends the oxygen gradient by reversibly binding to cytochrome C oxidase. And it also modifies complex 1 and complex 4, prevents superoxide production, again, improves the efficiency of ATP production with less oxygen. And what about stem cells? So the older we get, the less stem cells we have, but more importantly, we don't repair and recover as we did when we were younger. And so we're just wearing ourselves out, but we can replace and restore normal cellular function if our stem cells become active and mobile. And these are the papers showing that nitric oxide is required for stem cell mobilization and differentiation into target cell types. And then we published this paper in 2011 showing that the availability of nitric oxides may predict stem cell therapy success or failure.
Because a lot of people sorry to interrupt, but a lot of people are traveling to different clinics to get that stem cell therapy and show the benefits of that part of it. And so it's
and there's as you know, the data is all over the place. People get stem cells, some people get better, some people see no results. So why is that? Mm-hmm. Well, if you don't create that niche by nitric oxide, then these stem cells, especially if you're taking stem cells from a sick patient and putting them back into a sick patient, the stem cells just don't know what to do or what to become. So we're finding if we can titrate up their nitric oxide levels, then the effects, the therapeutic benefits of whether autologous stem cells or exosomes or things like that become more effective. So now let's get into something you guys are very familiar with, and that's vascular biology. Obviously, the older we get, we start to get plaque deposited under the lining of the blood vessel. The arteries become stiff, non-responsive, non-compliant. And if you have a little bit of plaque, it can be a 10% stenosis, 10% occlusion, and this plaque can become unstable and rupture, and that's a heart attack or stroke. So the stability of this plaque and really the whole process of plaque deposition is dependent upon endothelial nitric oxide production. So when we lose the ability to make nitric oxide in the endothelium, that sets the stage for this inflammation, oxidative stress, and immune dysfunction, which results in plaque deposition, plaque instability, and plaque rupture. So nitric oxide is what controls and regulates everything we know about atherosclerosis, plaque instability, and acute myocardial infarction. So what causes arteries to age? And I've mentioned this before, but it's inflammation, immune dysfunction, and oxidative stress. If we look at the three sources of oxidative stress in the cell, it comes from three primary sources: NADPH oxidase, uncoupling of the mitochondrial electron transport chain, and an uncoupled NOS. But these citations and references shows that nitric oxide actually corrects all of these. It's self-fixing. So if you can produce nitric oxide, it shuts down NADPH oxidase, recouples the electron transport chain, and if we recouple NOS, we produce nitric oxide, shut down superoxide production. So the question is, how do we control and regulate nitric oxide? And I'm not going to go very deeply into the biochemistry, and we don't have, in 45 minutes, we can't really delve that deep. But there's two ways the body makes nitric oxide. One is through the NOS enzyme, the oxidation of arginine, and the other, which I'll present a little bit of data on because it's relatively new and most people don't appreciate it, but it's through diet. Now we can use diet as a means to improve our nitric oxide production. So this is how a healthy artery is supposed to work. So if you can appreciate, this would be the single layer of endothelial cells. This would be the lumen of the blood vessel. And this is the smooth muscle that surrounds all blood vessels.
And that's what's
So when we
happening
begin-
inside the blood vessel, right? That's the stuff that's
Yeah, this would be a cross section of the blood vessel.
Yeah.
So when we begin to exercise, that causes shear stress. That turns this nitric oxide synthase enzyme on, produces nitric oxide. And that's why exercise is medicine. Because if you have a healthy endothelium, it produces nitric oxide. And then that nitric oxide diffuses into this smooth muscle where it activates an enzyme called guanylyl cyclase. And that enzyme converts GTP into cyclic GMP. And then cyclic GMP is what's responsible for the calcium-dependent relaxation. And drugs like Viagra, which are referred to as phosphodiesterase inhibitors, prevent the breakdown of cyclic GMP. So PD5 inhibitors are not nitric oxide releasing drugs. They potentiate the effects of nitric oxide. And in fact, 50% of the men that are given Viagra don't respond with better erections. And the reason is they're not making enough nitric oxide to activate the signaling cascade. So there's no cyclic GMP available for these drugs to inhibit the breakdown. So now we know that erectile dysfunction is a symptom of insufficient nitric oxide production, not a symptom of overactive phosphodiesterase. If we look at the function of this enzyme with age, we lose about 10 to 12% of this function per decade. So by the time we're 40 years old, we only have about 50% of the nitric oxide we had when we began. And your ability to produce nitric oxide predicts your exercise capacity. So these are young, well-trained athletes. You start them on an exercise regimen, their plasma nitrites increase, which is indicative of increased nitric oxide production. Now, if you do this same treadmill test in older patients with known cardiovascular risk factors, they fail to increase nitric oxide, they fail to increase plasma nitrite, and this is actually diagnostic for ischemic heart disease. The coronary arteries don't make nitric oxide, and they fail an exercise stress test. So how do you correct this? You know, for years, people thought arginine, you could give arginine and make nitric oxide. But now we know
the out there today talking about L-arginine and products that, hey, take the L-arginine as a...
Yeah, look, I mean, these are people that are either completely naive about nitric oxide biochemistry and enzymology or just ignorant because you need all 8 of these cofactors to convert arginine into nitric oxide. And the rate limiting step is the oxidation of BH4. So there's never a deficiency of arginine. So to me, it's never made sense as a biochemist to supplement with arginine. And I'll show you that at the very end. And why is this a bad idea? This is a paper in 2006 where they gave arginine to post-infarct patients. And those patients getting the arginine had a higher mortality. And this study was stopped halfway through because people getting the arginine had a higher mortality. So the results from this study is that arginine should not be recommending in acute or post-infarct patients. Same thing, give it to patients with peripheral artery disease, they get worse. So arginine should not be administered to any patient with endothelial dysfunction. So now let me take you back 20 years because this was really our kind of approach was, can nitric oxide protect the myocardium from injury from a heart attack? I mean, cardiovascular disease, #1 killer of men and women worldwide. And so our thought was, if we enhance nitric oxide production, can we prevent myocardial infarction and sudden cardiac death? And then could we trace this phenotype biochemically? And we did this in mice, so we could transfect these mice with a cardiac-specific transgene to overexpress the nitric oxide synthase enzyme. And you can see here the Western blot, the transfection was successful. And if we give these mice a heart attack, they don't see any injury to the heart. So we can shut off the blood supply to the heart for 60 minutes, reperfuse for 24 hours, and then look at the amount of injury to the heart. And these mice don't see any injury to the heart. We also started sampling the blood and the tissue of these mice. And what we found was the liver of these mice, the biochemistry was changed. And understand that nitric oxide, once it's produced, it's gone in less than a second. So it could not survive transit from the heart to the liver. So what's causing this change in liver biochemistry? And what does it mean? So then we shut off the blood supply to the liver for 1 hour and then reperfuse for 5 hours. and found that the nitric oxide produced in the heart protected the liver from ischemia reperfusion. So what does that mean? It means that we were the first people to discover a hormone function of nitric oxide. So just like testosterone produced in the testes provides cardioprotection in the heart, nitric oxide produced in the heart would protect the liver, the kidney, the brain, all organs. So this was the first indication that nitric oxide was a hormone. So then the thought was, well, can we replete through the diet? And so we basically took these mice and put them on a standard American diet, which is basically depleted of any nitrate or nitrite from green leafy vegetables. And what we found was if we subjected these mice to acute myocardial infarction, that they not only had a higher infarct, but about 50% greater mortality. And if we gave this back in the drinking water, either nitrate or nitrite, we had 100% mice survive up to 24 hours, and they had about 60% less infarct or injury to the heart. Next was if we take the enos deficient mice and we put them on a Western diet. So this would be the equivalent of a 50-year-old diabetic, overweight patient with erectile dysfunction or hypertension. And so you can see here that we can modify these nitric oxide metabolites through the diet. And if we subject these mice to 60 minutes of ischemia, 24-hour reperfusion, you can see here the white is dead tissue, what we call infarct. You can see here the mice that gets the nitrite in the drinking water is protected. There's much less injury in the heart, and the function of the heart, the pumping function of the heart, is restored. What about diabetes? We've got a global epidemic of diabetes. Once you develop diabetes, it shuts down nitric oxide production, and that's what leads to the increased cardiovascular disease severity. However, when we looked at the enos deficient mice, they became insulin resistant with type 2 diabetes. So this suggested to us, if you have deficient nitric oxide production, this leads to insulin resistance. If you don't correct the nitric oxide, you develop diabetes. Once you get diabetes, it further suppresses nitric oxide production. So we started to interrogate the insulin signaling pathway to figure out where is nitric oxide playing a role in insulin signaling, glucose uptake, and the management of diabetes. And this is a very complex signaling cascade, but we published this in 2014, showing that nitric oxide, the enos enzyme, is required to produce nitric oxide to allow for GLUT4 translocation. But we know in diabetics that this enzyme isn't functioning, so there's no nitric oxide being produced. And in this experiment, we tagged the GLUT4 protein with green fluorescent protein. And so you can actually see in real time the GLUT4 go to the membrane, bind glucose, and bring it into the cell. So we could improve insulin signaling, improve glucose uptake, improve hyperglycemia and the hyperinsulinemia seen in insulin-resistant type 2 diabetes. And similar to cysteine residues on hemoglobin, there's 2 cysteine residues on this protein that are post-translationally modified by nitric oxide that tell that protein now to bind glucose and get it out of the circulation. And so this shows really the fundamental nature of nitric oxide in improving insulin signaling and managing the hyperglycemic hyperinsulinemia of diabetes. What about inflammation? We all know that inflammation is the killer. The earliest stages of inflammation are when monocytes and neutrophils and platelets start sticking to the lining of the blood vessel. They migrate through and they start this whole foam cells, plaque. And what I showed you earlier is this whole progression of cardiovascular disease. And this here is real-time intravital microscopy of an inflamed blood vessel. So you can see here a lot of monocytes and neutrophils have stuck to the lining of the blood vessel. There's a little bit of blood flow getting through here, but this is a heightened state of vascular inflammation due to a poor diet. Then the question was, can we ameliorate the inflammatory response to a poor diet by restoring nitric oxide production? And here we give that same atherogenic diet, but we restore nitric oxide production. And you can see here this blood vessel is more dilated. These monocytes and neutrophils don't stick and they don't migrate through. So this shows that nitric oxide is completely anti-inflammatory, even in the face of a really bad diet. And I show you this because this is really cool. I had a cardiologist that came and worked in my lab for 5 years, and he was trained in China and traditional Chinese medicine. And these medicines have been used for thousands of years throughout Asian and Eastern countries. But no one knows how these indication or how these herbs or tinctures work. So I asked this cardiology fellow to go to a local acupuncture shop and bring me back any herb or tincture that he would use to treat a patient with high blood pressure, coronary artery disease, heart failure. So he brought back about 10 or 12 of these, and we published this in 2009. But we actually ground these herbs up and put them in a nitric oxide analyzer so we could detect nitric oxide gas. And you can see the first couple of herbs we put in here, nothing happened. Washed it out. We put another one. We get a little bit of nitric oxide being produced. Wash it out. Put another one in there. We get this peak of nitric oxide and then the sustained nitric oxide release. And we washed that out and we said, let's just add these two together, put these two together. And so we could quantify the synergy that's been described in traditional medicines for thousands of years by its ability to produce nitric oxide. So we wash it out, we do it again, and we get the exact same thing. So now we had the ability to produce any level of nitric oxide we wanted based on how we combined these rational combination of different herbs. And what about diet? So now let me show you the importance of diet. The vegetables that we eat that are grown in the soil contain nitrogen oxides, primarily inorganic nitrate, that the bacteria will fix nitrogen or ammonia into nitrate. And then the vegetables or plants that are grown in the soil accumulate nitrate, or the animals that we eat that eat the grass, we're getting a source of these nitrogen oxides. Now, when we consume, for example, spinach or kale or arugula or lettuce, we're getting a source of this nitrate that 90 minutes after we consume this, it's concentrated in our salivary glands. So now each time we salivate now for this next 6, 8, 10 hours, our salivary glands are secreting nitrate. There are bacteria that live on the crypts of the tongue that reduce nitrate to nitrite. We swallow our saliva. Nitrite becomes protonated as long as there's stomach acid being produced, and we get nitric oxide gas being produced in the lumen of the stomach. So that's how the system is designed to work. We get a lot of nitrate from the diet. The bacteria in our mouth reduce it into usable forms like nitrite or nitric oxide. We swallow our saliva. As long as the stomach can make stomach acid, we get nitric oxide produced. So let's take this step by step. How much nitrate do we need in a single meal? We need at least 300 to 400 milligrams, but the standard American diet, we're only getting about 150 milligrams per day. So just like most Americans are deficient in selenium, iodine, chromium, we're deficient in nitrate. We actually modeled a lot of these dietary patterns. So the dotted line is the threshold you would need to see any appreciable nitric oxide production. Most all dietary patterns fall below this, except the Japanese diet, and then the dietary approaches to stop hypertension. And the reason it stops hypertension is because of the nitrate content that the body can then convert into nitric oxide. So we went to 5 cities across the US because the next question was, how much broccoli or celery or spinach would I need to eat to get this 300 to 400 milligrams to normalize my blood pressure? We published this in 2015, and this is a very busy table here, but we went to Chicago, Dallas, Los Angeles, New York, and Raleigh. And let's just take celery, for example. So if you live in Dallas or Los Angeles, you could go to the store and buy 5 stalks of celery, eat those 5 stalks of celery, and get enough nitrate to normalize your blood pressure. If you lived in New York, you'd have to eat 40 or 50 stalks of celery. And it's the same thing. There's regional differences in the nutrient density of all vegetables. So there's no way we could make recommendations on how much you would need to eat because it depends on where you live and what vegetables you were eating. We compare this to organically grown vegetables. So these are conventionally grown vegetables. Organically grown vegetables have on average 10 times less nitrate than conventionally grown. So people think organic is good. Organic is good because you're not getting herbicides and pesticides. But organically grown vegetables are deficient in most nutrients, including nitrate. The other problem is 200 million Americans wake up every morning and use mouthwash. 200 million prescriptions written for antacids, and 200 million prescriptions written for antibiotics. So to me, it's no wonder why Americans are sick, because everything we do is shutting down nitric oxide production. So what about mouthwash?
Can we go back to that slide? I think that's
of course.
I think we really have to highlight that part there.
Yeah. So we were talking about the necessity or the importance of the oral microbiome in metabolizing nitrate. So here are the data. If you take normal intensive patients and all you do is give them a mouthwash twice a day for 7 days, their blood pressure goes up. And again, no change in diet, no change in exercise. The only thing we're doing is giving them mouthwash, and their blood pressure goes up. So the question is, what bacteria are responsible for managing systemic blood pressure? Because this is a completely new concept in cardiology. And this made sense to us because the microbiome provides 3 million gene products to the human. The human genome only codes for 23,000 genes. So these bacteria that live in and on our body are designed to do things that we as humans can't do. So about 10 years ago, we went in collaboration with the dental school at the Texas Medical Center. We just started doing tongue scrapings to see if we culture some of these bacteria that are responsible for the management of blood pressure. And what we found was that people who had the greatest diversity in the microbiome had the best blood pressure. Those that had the least diverse oral microbiome had kind of the worst oral microbiome and the highest blood pressure. So this was a nice association, but it wasn't causation. But this provided a clear indication to us that certain bacteria were necessary to have good blood pressure. Now we went back and we did another study, and now we only took young, well-trained athletes with a good oral hygiene. So these were dental students, oral hygienic students. And then we gave them mouthwash twice a day for 7 days. We did daily tongue scrapings, and to see what was the mouthwash doing to the oral microbiome, and did this have any effect on their blood pressure. And we published this a couple of years ago in 2019. But this was one 19-year-old dental student. He was a well-trained triathlete. 7 days after mouthwash, his blood pressure went up 26 millimeters of mercury. So we made a 19-year-old kid clinically hypertensive simply by giving him mouthwash. And 4 days after we stopped the mouthwash, his blood pressure normalized. Interestingly, we found that we could detect the bacteria that disappeared when his blood pressure went up, and we found bacteria that reappeared when his blood pressure normalized. When we sequenced these bacteria, they were expressing these nitric oxide producing enzymes. And we could predict steady state blood pressure by the presence and number of these 4 bacteria. So let me put this in perspective. This right here explains resistant hypertension. And for those of you who don't know what resistant hypertension is, if you have high blood pressure, you go to your doctor, he puts you on an antihypertensive. It's usually an ACE inhibitor, an ARB, or calcium channel antagonist, or a diuretic. But yet 50% of the people that are given those medications don't respond with better blood pressure. And why is that? Well, it's not a renin-angiotensin problem. It's not a calcium dysregulation. What we're suggesting is hypertension is a symptom of oral dysbiosis. So now when we understand that, and you start to interrogate your patients and go, hey, do you take a mouthwash? And 2 out of 3 people do. You get them off the mouthwash, get fluoride out of their diet and their toothpaste. Now the bacteria can actually flourish and their blood pressure normalizes. It's really an amazing phenomenon. So based on that, we had enough data to really come to market with a nitric oxide-based product technology. Now we've got drugs in phase 3 clinical trials. But I'm going to take you very quickly through a number of clinical trials. So we developed an orally disintegrating tablet. So this lozenge, when it slowly dissolves in the mouth, it generates nitric oxide gas. And that's illustrated here. We can detect nitric oxide coming off. It takes about 5 minutes to completely dissolve. And it normalizes blood pressure. So these are unmedicated hypertensive patients. You can see here the lozenge within 20 minutes reduces systolic and diastolic blood pressure. 60 minutes later, there's a further reduction in blood pressure. And then 4 hours later, we see a 15% improvement in endothelial function. So we've recoupled the nitric oxide synthase enzyme and basically restoring normal endothelial function. So if you have an endothelial dysfunction, the nitric oxide lozenge reverses endothelial dysfunction and improves endogenous NO production. If we look at the carotid artery at baseline and then 10 minutes after the lozenge, you can see here 10 minutes after that lozenge, we've increased blood flow through the carotid by 34%. Even people with plaque, these are asymptomatic carotid plaque, 6 months on the nitric oxide lozenge, we see 11% plaque regression. So just as you can extend telomeres, you can reverse cardiovascular disease, reverse plaque. And now let me finish up here in the next 10 minutes and we'll open it up for questions. But this here is a study we did at Texas Children's Hospital in a group of pediatric patients that have a genetic disorder. So these patients are born without an enzyme called arginose-succinate lyase. And so their primary problem is it's a urea cycle disorder. So they develop high ammonia levels. They have liver dysfunction. These kids will die of liver failure at 7 or 8 years of age unless they get a liver transplant. They develop blood clotting disorders. They have neurological dysfunction, cognitive disorders. They have resistant hypertension and kidney disease. So these physicians came to me in 2006 and said, can you help us understand this disease? And we published this in Nature Medicine in 2011. But what we discovered was that this ASL protein that these kids do not have is what tethers this nitric oxide synthase enzyme to the cell membrane. So in these kids that don't have this protein complex falls apart and they've lost the ability to produce nitric oxide. Now this explained, the lack of nitric oxide explained every single one of these systemic disorders that was previously unexplained by the best pediatricians, geneticists in the world. So now what does this mean? Can we rescue these patients that cannot make nitric oxide? And this is the data here. This is a single patient, an ASA patient. You can see at 5 years of age, he was diagnosed. He had severe hypertension for really 10 years, poorly managed, even though he's put on a number of different antihypertensive medications. And in February of 2010, he came to Texas Children's. He was put in the pediatric intensive care unit, and his blood pressure was 200 over 115, a 15-year-old kid, and nothing would affect his blood pressure. But by then, we knew that this protein complex was missing, and he was deficient in nitric oxide. So then his physician started dosing him with isosorbide, which is an organic nitrate that's metabolized into nitric oxide. And within 4 days, he was released from the hospital and his blood pressure completely normalized. But he developed tolerance to this organic nitrate. And in February of 2011, he came back to Texas Children's. And his blood pressure was 185 over 110 when I saw him. And I made him a lozenge. And I started giving him this lozenge. And within 4 hours of this orally disintegrating tablet that generates nitric oxide, his blood pressure completely normalized. And within 4 hours, he was released from the hospital. And we followed him for 12 months. And within 12 months, he was off all prescription medication. He graduated high school, and we published this in the American Journal of Human Genetics. We're now 7 years out. The kid has done phenomenally well. He graduated high school. He beats his dad in chess now, and he's off all prescription medication. This just goes to show you that the nitric oxide is extremely potent and beneficial, even in patients with a rare genetic disorder. His heart disease resolved within 5 months. So when we saw him at 15 years of age, he had a heart twice the size of a normal 15-year-old. 5 months after we started the lozenge, his heart completely remodeled, normal function, normal size. And his kidney disease resolved within 5 days. And if you look from a public health perspective, if you just lower blood pressure by 5 millimeters of mercury, reduce the risk of stroke by 1/3, and reduce the risk of ischemic heart disease by 21%. Let me take you through very quickly, because now we've taken our nitric oxide technology and basically integrated this into a topical. And we're now developing it into a phase 3 drug for diabetic ulcers and non-healing wounds. But about 4 years ago, we brought this to market as a beauty product because we knew how to make nitric oxide. The skin is an organ. Without sufficient blood flow, that organ fails. So I developed a dual chamber nitric oxide topical. You take one pump from one side, one pump from the other, you mix it together, and you create nitric oxide gas. So I'm going to take you through this is applying the serum twice a day for 30 days. You can see here these age spots disappear. The inflammation on the chin goes away. The inflammation on the neck, look at the tone, texture, and clarity. So when we give nitric oxide for 30 days, I mean, this is transformative in terms of fine lines and wrinkles. The varicose veins go away. This is a lady who developed a full thickness ulcer after a facelift. We just applied the serum in and around the wound. 10 days later, got complete closure. Polycystic acne, it kills the bacteria in these pustules, reduces the inflammation. This lady here had suffered for 10 years with polycystic acne. Nothing would help it. Our topical nitric oxide resolved it within 30 days. This is a 15-year-old scar from teenage acne. 30 days using the nitric oxide, you get, I mean, almost complete resolution of a 15-year-old scar. Let me just briefly visit on COVID because we treated over 600 patients with our nitric oxide drug and COVID. We improved oxygenation. The problem with COVID is like that video I showed you earlier. The spike protein binds to these ACE receptors and causes the monocytes and the neutrophils and the platelets to stick. You get microclots, and this is the systemic disease of COVID. And we know that nitric oxide prevents all this from happening. And we knew that nitric oxide actually inhibits the replication of the coronavirus. And here's one patient from our study. You can see this patient had a blood oxygen saturation of 79. He took his drug. 8 minutes later, his blood oxygen saturation improved to 91. So these were the effects we were seeing in an outpatient FDA phase 3 clinical trial. We stopped the trial because people stopped getting sick from COVID. The disease changed over time. But the results were we treated over 650 very sick patients. We improved blood oxygen saturation. But more importantly, there was not a safety signal. So this drug was extremely safe and made people better. Here's some data from our topical nitric oxide drug. You can see here that it's antimicrobial. This is a Pseudomonas plate here. Works just as good as penicillin. I mean, this works just as good. Here's some diabetic ulcers, non-healing diabetic foot ulcer. 30 days using the serum, we completely healed this wound. Here's a 52-year-old second-degree burn. We get complete healing using the serum for 21 days. 64-year-old paraplegic with a non-healing wound for 3 years. We started using the nitric oxide serum, and we completely healed this non-healing wound in 195 days. So going forward now with our drug company, we can go straight into phase 3 clinical trials with all of our oral drug formulas. Now we've got a drug for ischemic heart disease, ischemic non-obstructive coronary artery disease, and we've got a drug going into an Alzheimer's drug study. Here's kind of the pipeline for that. We're rapidly moving forward with our investigational drug applications to try to get some safe and effective nitric oxide drugs on the market, hopefully in the next year or two. Let me just end with kind of bringing this back to, is this what nature intended? When we ask these questions, because we never want to give the body something that it hasn't seen. And so this guy here is now Lincoln, my 15-year-old, but when he was born at the Texas Medical Center, when we were being discharged from the hospital, the discharge nurse gave us some formula and said, well, if you don't want to breastfeed, give the baby this formula. So I kidnapped my wife, and when we left the hospital, I took her to my lab. I got some of her breast milk and I compared it to what was in the formula. And the breast milk was replete in nitrite. There was hardly any in the formula. So based on this, I went to the IRB, the Institutional Review Board, and I collected milk at Memorial Hermann in the labor delivery unit. And what we found was that the early colostrum had a lot of nitrite. As it matured in the transition to mature milk, this changed and it switched over to nitrate. And so you ask yourself, why is that? Well, babies are born sterile, right? They don't have the bacteria that are necessary in the mouth to reduce nitrate to nitrite. So in the colostrum, the breast milk provides a source of nitrite until the bacteria colonize. Then it switches to nitrate so the bacteria can utilize that on their own. The other answer came in studying people at Tibet. We went to Tibet. These people live at 12,000 feet above sea level, but they don't get mountain sickness. They don't get altitude sickness. And the reason for that is they deliver more oxygen per unit time than we in the US. They have 50 to 100 times more nitric oxide being produced than we do in the US. So the adaptive benefits of altitude training is the upregulation of nitric oxide production. So now if we go to Colorado or Ethiopia and train, or Mexico City, then we increase our nitric oxide production. And that's the benefits of altitude training. So let me just wrap up here and we'll open it up for questions. People ask me all the time, how do I restore nitric oxide? We only got to do two things. Stop doing the things that disrupt it and start doing the things that promote it. If you use mouthwash, you have to stop using mouthwash. Get rid of fluoride in your toothpaste. Get a home filtration system to remove the fluoride from the drinking water. If you're using an acid, you have to stop. And then, it's a balanced diet in moderation, moderate physical exercise, 20, 30 minutes of sunlight a day. And then when all else fails, we have technology that does it for you. If we get this sign here on our smartphone, we go plug it in, right? We're losing charge. Well, our body loses charge over time. We lose nitric oxide. And if we don't recharge, we die. So we have to pay attention to the symptoms of the red light coming on saying, hey, something's wrong. And I like this quote by Stephen Hawking: the greatest enemy of knowledge is not ignorance, it's the illusion of knowledge. And we've certainly survived an illusion of knowledge over the past 4 years. Ignorance is curable. It's just knowledge and information. So I'll just wrap up here that nitric oxide controls and regulates blood flow and oxygen delivery to every cell in the body. There's an age-related decline that asserts itself on cardiovascular risk. Diet and exercise are not always sufficient. We're seeing with our drug studies that I'm absolutely convinced that nitric oxide will have a profound impact on public health and the future of medicine. And your body cannot and will not heal without nitric oxide. I'll leave you with a couple of references here. There's a book. There's my email. I'll stay on and answer questions, but if you think of a question later on, there's my email there. I've got an educational website, got a 6-minute video on there that's really good kind of education and information on nitric oxide. And those of you interested in our product technology, you can find that at n101.com. So Diamond, thanks so very much for the invitation to present and kind of share the research and discoveries we made over the past 20 years and how we're translating that now into patient care.
Yeah, thank you very much for that, that information. I think it obviously reiterates what we're trying to accomplish, especially when I talk about artery disease. And I think that the reason why we see so much success with healing the artery wall, inside the artery wall, I talk about it all the time, it's all skin, it's endothelium. And we talked about this, I think, a while ago, but using that same application to bruises or to burns or to improving facial or skin abnormalities, it's a no-brainer because it does the similar thing. So can you comment on that part of it, just for our listeners, as to how that relates so well? Because the endothelium, the epithelium, all those things are very similar, right? And so,
so the endothelial cells contain nitric oxide synthase, epithelial cells contain nitric oxide synthase. So when that enzyme becomes uncoupled, you lose the regulation of blood flow to that organ. So the skin is an organ just like the heart, the brain, the sex organ. And without sufficient blood supply, then that organ fails. So what we do is we do it two ways. So we give the lozenge to open up the small blood vessels kind of that are deeper than just the superficial veins or superficial capillaries. Because when we apply nitric oxide topically, there's really a limit of diffusion of how far nitric oxide is going to diffuse into the tissue. So if we take the lozenge, apply topically, now we're really getting blood supply wherever we apply topically and systemically. So when you open up capillaries and restore blood flow, now you get oxygen and nutrients to those individual cells, and they can actually do their job.
I also love the idea of explaining this to patients. I think I heard it from you first, is that, if we take all the arteries and attach them together, it would go around the world a few times. Like, that's how many arteries we have. And so when we talk about improving nitric oxide, we're improving nitric oxide to everywhere blood goes. And this is why we see so many benefits. Like, one of the treatments that we do in our clinic is external counterpulsation therapy. And sure, we talked about that already. And it's one of my favorite treatments to help the arteries of the heart, but it does so many more side benefits because the arteries go everywhere. And the same thing happens when you start to improve nitric oxide production. Blood flows everywhere, and that's why you see so many side benefits. I call it from improving nitric oxide too. So
yeah, no, all these modalities work, and you can actually make them work better if you restore the function of the NOS enzymes. So a lot of the technology we develop prevents BH4 oxidation. So now if you're doing, ischemic preconditioning or the counterpulsing, and now that adaptive effect is an upregulation in nitric oxide production. So now you're getting cardioprotection of increased nitric oxide. But those modalities only work if the eNOS enzyme is recoupled and can actually make nitric oxide.
Yeah. If anybody has any questions, you're more than welcome to use the chat there. On there, I see one. Can taking supplements, and I know you talked about this already, such as L-arginine or L-citrulline, significantly boost one's nitric oxide? I'll let you comment on that one there.
No, I mean, only if the eNOS enzyme is coupled and functional. And people with endothelial dysfunction, I mean, the mechanism of their dysfunction is that enzyme is not coupled. So citrulline is a byproduct of nitric oxide production. So you're further steps away from arginine. Arginine requires a 5-electron oxidation to get to nitric oxide. And our body, arginine is a semi-essential amino acid. So even in the sickest of sick patients, you have 100 to 200 times more than what's needed to saturate the binding site to the nitric oxide synthase enzyme. So arginine and citrulline are completely useless in terms of generating nitric oxide because we're never deficient in that. If you're deficient in vitamin D, it's helpful to take vitamin D. If you're deficient in vitamin or other minerals, then you can replete that. But we're never deficient in arginine or citrulline. And the data I showed you, if you give arginine, high-dose arginine to patients with endothelial dysfunction, you actually make things worse.
And we have used that, and I've tested this product in the past using L-citrulline. We don't even see as close to the benefits with lozenges or other products that do it through the right pathway. And so we definitely
no. So if you go back to just to reiterate here, if you look at how citrulline. So if you look at this. One more. If you're giving citrulline, then citrulline has to go and be converted to arginine through arginosuccinate synthase, arginosuccinate lyase, and then has to be converted to arginine. And then arginine has to go through the NOS. It requires this enzyme to be coupled to generate nitric oxide. So citrulline is a byproduct of nitric oxide production. And in most biochemical reactions, there's feedback inhibition. So giving citrulline will actually lead to a feedback inhibition of this pathway and shut down nitric oxide production. The citrulline is not, unless you've got a urea cycle disorder or a deficiency in one of these enzymes, then citrulline is certainly not the answer.
And we've tested that on our own as well there. So there's a really good question here as well. So the answer to that question is so no.
Yeah.
You L-arginine and citrulline can boost nitric oxides. We talked about going through the right pathways. I've been using nitric oxide lozenges for a long time. Can I expect a regression in my carotid arteries from regular use or duration of use? Because that was the question.
Well, the one study we published was patients that had really what's called asymptomatic plaque. Not something that's causing more than a 5 to 10% stenosis of the carotids. And that was taken one lozenge twice a day. And what we found was if you did that for 6 months, we saw 11% plaque regression. That was only in, I think, 10 or 11 patients. So it was a small group. But I think it's certainly what we're finding is we've seen this anecdotally outside the clinical studies that people who've had, severe carotid plaque, within a period of 6 months or a year, get complete reversal. So, my job is to manage expectations. I can't definitively say yes, but there's evidence of that in the published literature.
Yeah, and it's I think there are other steps to understand it when it comes to improving artery health and artery disease, and we can get into talking about glycocalyx, and I know we bring in some other people to talk about that part of it. But can you comment on that part specifically when we talk about improving artery health? Improving the glycocalyx is the hair-like structure that comes off those individual endothelial cells. And so can you comment quickly on that part of it? Because I think it also comes beyond nitric oxide production as well. So.
Yeah, the glycocalyx is completely separate from the endothelium. So restoring the glycocalyx is not necessarily going to restore endothelial function. But if you have a disruption in the glycocalyx, then what it does is it subjects the endothelial cells to a lot of the shear stress and the damage caused by, rolling monocytes and neutrophils. So the glycocalyx is extremely important, but fixing the glycocalyx will not necessarily fix the NOS enzyme and fix endothelial dysfunction.
Yeah, and that's important. So especially on that end of it. If there are any more questions, as you know, you can have access to, he's left his contact information there, and
yep.
He's very active on there. And so I think there's one more question here that came through. Do you think there could be any synergy between nitric oxide lozenges and statin therapy at all?
I'm not a big fan of lowering cholesterol. I think if you get your cholesterol below 200, then you become deficient in vitamin D and testosterone and estrogen, because these hormones and vitamin D are made on the cholesterol backbone. The other thing too is when we're finding that chronic statin therapy disrupts that lipid raft in the membrane, and then you lose the regulation of intracellular signaling. So to answer your question on really the objective is to mitigate known risk factors. Total cholesterol is really no predictive or prognostic value on risk of MI. Now there's the standard lipid panel where there's total cholesterol, HDL, LDL. To me, it's meaningless. You need to do advanced lipid and look at triglycerides, look at oxidized lipoproteins, certain number of lipoprotein particle size and number. And when you look a little bit deeper, nitric oxide prevents oxidation of lipoproteins. One of my patents is on a method of lowering triglycerides. We see a 30% reduction in triglycerides just using the nitric oxide lozenge alone. So I think the thing here, the goal is to mitigate a lot of these known risk factors that lead to cardiovascular disease, and cholesterol does not cause heart disease.
And that's something we've been talking about quite extensively. And I think I'll take us back quickly earlier in the presentation when he talks about that, because inside the artery wall is all skin. We talked about inflammation, right? Something has to damage that lining of the artery wall. Then we talked about oxidative stress, where those cholesterol particles do seep through and get oxidized or broken down. And then lastly, then there's a big immune response or an infection response that happens to the lining of the artery wall. And those are the three important things to understand when it comes to artery health in a simple 3-step way, is to understand that inflammation, then these particles that seep through as a result of inflammation, and then controlling the immune response on that side of things. And so that's where cholesterol is never been about lowering cholesterol. It's always been about minimizing those particle sizes, getting oxidized and broken down. And I always talk about it like an apple. You cut it in half, it gets browned and oxidized. The same thing happens to anything that slivers into the lining of the artery wall. So that's super important to understand.
Yep. So there's one, what do you do when your cholesterol is good, but you have stenosis? Well, and we published on this, you can have reverse cholesterol transport. So, if there's stenosis or plaque there, then, just because you will find cholesterol in plaque. That's how this whole kind of hypothesis came about. But what you have to do is prevent the inflammation, immune dysfunction, oxidative stress. That's what leads to plaque vulnerability, plaque instability, and plaque rupture. So there's patients who have 90% stenosis in their coronary arteries, but have no symptoms. They may have a little bit of exertional angina, but that plaque is stable and there's no risk of rupture. To the contrary, you have patients with less than 10% stenosis that have vulnerable plaque, that have plaque rupture, and have sudden cardiac death from the plaque. So it's not about the degree of stenosis. It's about the stability of the plaque if you have plaque. And you can do this through, calcium or coronary calcium scores, and you can look at the degree of stability of the plaque. If you've got a vulnerable plaque, and you can measure this through myeloperoxidase and some of these advanced inflammation panels, and that'll tell you how vulnerable the plaque is.
And that kind of takes me to understanding this artery, and we have an image that we're just developing in the clinic. Is that if you look at an artery again, you look at the artery, and we just look at a blockage up to 50%. So 50% or less, 10%, 20%, 30%, up to 50%. Anything less than that, that's where 70% of heart attacks actually occur. And that sounds funny to a lot of people, but if you take it one more level, crossing the threshold of 50%, between 50 and 80%, that's where 20% of heart attacks occur. And if you pass the threshold of 80%, that's where only 10% of heart attacks occur. And that sounds funny to a lot of people, but when we talk about the stability of the plaque, this is where nitric oxide becomes an important factor on that, or maybe you can comment on that further as to talking about plaque instability, because people think, and even smart physicians, come to our clinic and say, Diamond, you're all wrong. Even smart cardiologists will come to us and say, it's all about the stenosis and me opening it up with stent or bypass. And that's not what you want to do anymore. The data shows that, and the literature showing that for a couple of decades now on leaving these stenoses alone and only using that when you're actively having a heart attack or stroke. So maybe if you want to comment on that part of it with the plaque instability, and I think there's a question there.
Well, platelets and other immune cells want to stick to existing plaque. And one of the earliest discoveries on nitric oxide, this was done by a guy named Radomski back in the early 80s, showed that nitric oxide prevents platelets from aggregating, but it also prevents platelets from sticking to existing plaque or emboli. So if you take nitric oxide, or you restore the function and production of nitric oxide in the lining of the blood vessel, then it stabilizes that plaque. You don't have to worry about additional plaque being deposited. You don't have to worry about platelets becoming aggregated and that plaque rupturing. So it's really about stabilizing plaque, and you can do that mechanistically through restoration of nitric oxide, but more importantly, by eating, don't eat an inflammatory diet. Don't eat a lot of processed foods. Don't eat a lot of simple carbohydrates. And just get exercise, do all the common sense things that are known to kind of mitigate cardiovascular risk.
Absolutely.
Yeah, baby aspirin, lozenges. There's a lot of synergy between aspirin and nitric oxide. So you can actually synergize the effects of those. So 81 milligram baby aspirin is perfectly fine. With the nitric oxide lozenges, you're going to get a synergistic effect on preventing platelet activation.
I'll leave this as the last question, and just valuing your time there. So, does taking probiotics to improve healthy gut microbiome or healthy bacteria help with nitric oxide? Comment on that one quickly there.
No, we haven't found any oral probiotic or any commercially available probiotic that's affecting the nitric oxide producing or nitrate reducing bacteria on the dorsal part of the tongue. We've tested most, if not all, oral probiotics. So I'm not against probiotics. I think they're really good for restoring the gut, the gastrointestinal microbiome. But that community is completely different than the community we're interested in the dorsal part of the tongue.
Excellent. Well, I want to thank you for your time today. Having you on the call and having your expertise in the decades of research that you've been focusing on when it comes to nitric oxide has been super valuable. And so I want to thank you for your time today. And it's been a real privilege having you on.
Well, thank you very much.
Yeah,
It's
thank you
great
for
joining
always
you.
being a resource to us when it comes to improving nitric oxide. So
Anytime. Thank you,
Excellent.
Diamond.
thank you very much.
Bye.